everyone, respected judges and chairman sirs. Thank you for this opportunity. I'm going to talk about vitreoretinal and choroidal features of rhinoorbital mucormycosis, a longitudinal study. Rhinoorbital mucormycosis is a highly morbid and a rare disease. Recent literature has described retinal findings in the patient of rhinoorbital mucormycosis as central retinal artery occlusion mostly. However, pathological studies have shown mucor invading the choroid and the retina with neutrophilic infiltrates. So it is pertinent that retinal inflammation secondary to invading mucor has some role in the microstructural changes seen in vitreous retina choroid of these patients. With evidence of choroiditis, chorioretinitis, endophthalmitis in patients with orbital mucormycosis just limited to anecdotal case reports, there is a need of study of vitreoretinal and choroidal manifestation of these patients in vision-threatening rhinoorbital mucormycosis studied prospectively. SDOCT has an ability to provide optical biopsy of the retinal tissue, and comparing the SDOCT findings with the histopathology of the exentrated globes can help in histopathological correlation. The aim of this study was to describe the vitreoretinal and the choroidal features of the patient with vision-threatening rhinoorbital mucormycosis and how they evolve in time on spectral domain optical coherence tomography. The study should also provide insight into the pathophysiology of these vitreoretinal and choroidal manifestations by in vitro analysis of the exentrated orbital content. This was a prospective observational study carried out at GTB Hospital, New Delhi. 15 consecutive microbiologically, radiologically, histopathologically proven patients of rhinoorbital mucormycosis having acute loss of vision secondary to posterior segment pathology not attributable to any other systemic illness the patient had were included in the study. The outcome measures for retinal thickness, prevalence data of the SDOCT features, and histopathological correlation. For the inclusion criteria, a normal carotid Doppler and normal echocardiography was also must. All recruited patients were treated with standard treatment guidelines. Complete ophthalmic examination, including best corrected visual acuity, color fundus photograph, serial OCT, were done on weekly basis for 2 months. Central macular thickness, inner and outer retinal thickness measured 1 mm nasal to the fovea, with total retinal thickness measured 1 mm nasal to the fovea were recorded at all visits. Patient with absolute loss of vision, extensive orbital involvement, loss of enhancement of orbital tissue on MRI underwent orbital exentration. The exentrated orbital content was sent for histopathological evaluation. The 4 patients in our study, in our cohort, underwent orbital exentration. The minimal follow-up was of 1 week with the maximum follow-up of 11 weeks. The features like ILM detachment, inner retinal hyperreflectivity, inner retinal thickness, which has been described previously in patients with on OCT on previous patients with CROA. There were features like vitreous cells and vitreous haze, posterior hyaloid thickening with partial detachment, ill-defined optically empty spaces, hyperreflective dots in the outer nuclear layer. The vitreous haze, the vitreous cells, the posterior hyaloid thickening, ill-defined optically empty spaces, hyperreflective foci was seen best at the 4 week, or rather they were most prevalent at the 4 weeks, while the focal RP disruption was seen at the end of 2 months. This is the serial fundus photograph of patients showing retinal thickening, ILM detachment, inner retinal hyperreflectivity. Apart from that, we see focal optically empty spaces at the end of 3 weeks, which diminished on further follow-up, leading to optic atrophy. On the left-hand side, we see an OCT showing choroidal scarring, vitreous cells, vitreous haze, thickening posterior hyaloid. The histopathology of this patient showed thrombotic angioinvasion with disorganized retinal architecture. Apart from that, hyphae was seen in the mucor hyphae was seen in the choroid with neutrophilic infiltration in the retina. Another patient, apart from the inner retinal hyperreflectivity with progressive thinning, there was vitreous cells present over the disc. The histopathology of this patient revealed thrombotic angioinvasion of the disc vessels. The retinal thickness matrix, there was decrease in the progressive retinal thickening decrease from the thickened retina at the beginning with thinned out retina in the last follow-up. So the fundus images of this patient were consistent with the central retinal artery occlusion. However, the SDOCT finding that has been described in the previous case reports or the literature was consistent with the SDOCT findings of CRAO. Vitreous cells, protein-rich vitreous haze and posterior hyaloid thickening are the feature of posterior segment inflammation. Vitritis associated with retinitis is dependent on the immune status of the patient. Most patients in our history had the history of diabetes mellitus and a steroid intake associated with dampened immune response. Thrombotic infarction of the retinal arteries could be the reason for minimal vitritis seen in our patients. These focal empty spaces have also been described in necrotygic retinal retinitis. Necrotygic viral retinitis have these empty spaces because of the necrosis by viral-induced cytolysis and vascular occlusion. However, in our study, these necrotic spaces could be a spectrum of coagulative necrosis secondary to the vascular occlusion. The focal area of choroidal scarring could be a sequelae of local inflammation caused by the mucor hyphae. Histopathological examination also revealed mucor hyphae in the choroid and with intense neutrophilic infiltrates. Thrombotic infarction of the vessels by the mucor hyphae may precede the direct invasion of the occlusal course by the mucor, because sclera acts as a natural barrier for the invading mucor. So the sites for blood vessels and the nerve piercing the sclera could be potential weak point. That is the reason we saw vitreal cells at and around the disc. So in conclusion, I would like to conclude with early microstructural changes were primary result of retinal infarction secondary to thrombotic angioinvasion, while the late microstructural changes could be a possible sequelae of retinal infarction with sub-contribution from inflammation resulting from mucor invading the choroid and the retina. Thank you.